Right, so good evening, everybody. Asif, if I just do a quick sound check, can you just message me if you can hear me okay? Because I was muted. I think I've unmuted myself now. Is that all okay? Brilliant. Okay, so I can see Luke's joining us this evening and Asif sat in the background. So pleased to meet you. I'll introduce myself first of all. My name's John Swarbrick, and along with Luke Hutchins, who's on the call this evening with me, we run the Smile Fast Restore course. So what is Smile Fast Restore? Well, hopefully if you've dialed in and signed up for the evening, you'll have sort of read a little bit around it. And it's really Smile Fast, but sort of hopefully taking you to the next level to enable you to treat more multidisciplinary cases, and particularly around wear. So I have the great privilege of working in two practices. This is one of my practices that I work at, which is Dental Excellence at Harewood in Leeds. And this is a referral only practice. And specifically, I deal with full mouth rehabilitation cases, specifically cases that have advanced tooth wear. And really, I've been here for 10 years. And this practice in particular, we probably are treating at least 2 cases per day of advanced tooth wear and full mouth rehab. And we use Smile Fast, within those cases to enable us to rehabilitate them. And so on the back of that, that's really where a lot of the stuff that I'm going to discuss a little bit this evening, but mainly over the 2 days of Restore, are the principles which we use to hopefully safely and predictably restore wear cases. The other practice where I've worked the majority of my life is Farsley. And Farsley is just a general dental practice. It's a mixed practice. We have about 70% private, about 30% NHS. We deliver about 17,000 UDAs a year, and I've been there since 1992 when I qualified. So I've also the great privilege of seeing a lot of my work come back over a 30-year period. And so I think you learn as much from your failures and seeing what works long-term. And so a lot of the stuff that we share over the 2 days on Restore is not only clinically and scientifically based, of which we give you a whole bundle of probably 20 scientific papers to read, but also there's a little bit of anecdote, as there is with all dentistry, in terms of this is what works and this is what has worked for us. So I guess between myself and Luke, you probably got 50, 60 years of dental experience that we're able to share with you over the course of the 2 days. So the goal for me and my practice is to help all my patients retain their teeth for all of their lives, if possible, in maximum comfort, function, health, and aesthetics, and to accomplish this appropriately. And this realistically is what sits alongside the Smile Fast mantra. It's minimal, additive, sort of bonding work. The days of sort of preparing huge numbers of teeth is, moving away. And there's definitely a cohort of patients who are living longer and wanting to keep the teeth longer. And they want them, if you ask people, do they really want their teeth drilled? A lot of them say no. And I think we'd all agree with this next statement, is that advanced tooth surface loss is one of the biggest growing issues in dentistry. So exactly as I said, as people are living longer and keeping their teeth for longer, we're seeing more and more people present with tooth loss and tooth surface loss. And so the ability to be able to diagnose, treatment plan, and then treat this competently is absolutely paramount, not only for dental practitioners now, but moving forward, there may well come the time where dental wear is becoming more prevalent than actual dental disease and decay. So modern composites and adhesive dentistry enable us to conservatively plan and deliver what I would call biologically friendly restorations, which can basically enhance a patient's appearance and protect the remaining tooth structure. So teeth for life, that's my sort of mantra that I always say to my patients. And how are we dealing with worn teeth? When are we treating them? Who are we treating them, and how do we treat them? And part of the Restore course, we'll look at all of this over a 2-day program that we'll deliver for you. And our aim really for you at the end of the 2 days is to walk away, and we do a lot of case-based discussion, and we encourage you to bring cases along with you so that we can actually treatment plan with you as the group, with everybody on there. I do think there's a lot of shared experience, and when we look at if everybody can bring a case and we can look at all of those cases, suddenly across the day you may have looked at 20, 30 tooth wear cases. And I think with tooth wear, every case is slightly different in its own. So although there is a system and a process which we will teach you, you've then got to apply that on lots of cases. Nothing reinforces learning more than looking at a whole host of different cases that people have bought, because pretty much there's an element on every one that becomes a discussion point. And this is basically what we're seeing. Certainly in the north where I work, you'll see people with losing teeth, with collapsing bites, becoming overclosed, with chipped and worn teeth. And these are the people that we see on the portal that people are presenting. Can we help and can we do this with SmileFast? Can we bond this? Because it sits within their value set that they would rather sort of rebuild these teeth using composite and bonding techniques, perhaps rather than prepare the teeth for full coverage crowns. But all of these cases, which are on the screen in front of you, need occlusal reorganization, and therefore by definition are complex. And that's really where a few people come unstuck, because they're just not sure what steps should I do, what order should those steps be, what diagnosis should I arrive at, what's the etiology of these disease processes, and how can I therefore predictably and safely treat these cases to deliver a consistent outcome for my patients. And that fundamentally is, in a nutshell, what we cover. Now, these three factors will affect us all. You know, if this case in front of you now is on a 25-year-old, yeah, we're going to have to do something. There's a lot of aggressive non-carious tooth surface loss. But this isn't somebody who's 85 or 90 years old, then this may affect how we do it. And of course, age, budget, you know, how much the patient has, you know, available to spend. You know, if this presented perhaps in the 1970s or 80s, this might become an extraction and an overdenture case. Whereas nowadays, this is more likely to be rehabilitated using bonding techniques with composite. And of course, expectations. Patients now want to keep the teeth. People don't come in now and ask for all the teeth to be taken out. They want to have them restored. They're on Instagram, they're on Facebook, they see composite bonding. They'll come in and ask you about composite bonding. And of course, they all want it to look perfect because they all see multiple images across social media of how good it can be. And of course, in SmileFast Direct, we have a tool that gives us that really, really predictable result time and time again. Now, if we've got somebody younger like this, and I'm going to show you just across the market of people where we see tooth wear, interventionally, how do we diagnose and what do we looking at? So if we get somebody who's very, very young, like this young lady presenting, and her primary complaint is that she doesn't like her smile, she feels her two front teeth are too big. But if you look very closely at the upper right lateral, what you can see there is a sign of early tooth wear. You can see that the canine tip is already worn, and in crossover, that lateral is already starting to chip. So I want you just to remember this case, because this is one that we're going to come back to, because this is perhaps one whereby we went back a slide. Would we be looking to treat this case? Would we be looking to bond and idealize it? How do we diagnose what's going on here? And how do we perhaps idealistically versus realistically treat somebody who's very, very young at this age? And would we perhaps look to orthodontically correct what's going on here ahead of perhaps bonding? And I think that does play a role. So one of the first things we look at is age of patient and demographic of patient, and idealistic versus realistic treatment when we're dealing with tooth wear. The daughter test is always very, you know, apparent to me, because actually when you look at this smile, although head on it looks very, very good, when we start to photograph and analyze it, you can see altered occlusal planes, and you can sort of see why, by today's modern Instagram standards, she might be unhappy with her smile. But there is tooth wear going on. Now, there's other cases like this that we see in, I say these are the baby boomers, so people who are 50, 60 plus, who have lost teeth through 70s, 80s, legacy dentistry, as I would call it. And they've got reduced posterior support, they've got a collapsed bite, and they've got non-carious tooth surface loss that affecting upper and lower teeth. And again, with a case like this, would we perhaps be looking to do orthodontics, or could we be looking to do it a more realistic way? And how do we plan that? How do we diagnose it? And how do we communicate that effectively with the patient in terms of what their treatment options are? So again, the first day really is looking at a lot of these aspects that I'm talking about now in terms of how we actually diagnose, how we communicate, and how we then treatment plan in a sort of manner that keeps us medical legally safe. Because that's a big thing with these cases. If we're going to reorganize this bite because they're overclosed, there's no restorative space left there on the lower jaw to restore those worn edges. So how are we going to do that? Well, we're going to need to reorganize that case. And therefore, by definition, it's a complex case. Now, we know if I show you a picture like this, most of you, if you're doing SmileFast Direct, recognize this as a refined stage. It's a trial smile stage. And at this stage, we can start to talk about needing to do a little bit of minimal preparation on that front tooth. Now, again, if this person is late 60s, you know, maybe that's not the be all and end all, a little bit of light preparation. We can also then start to look, we've obviously opened up the vertical here. So we've started to look and restore those lower edges, and they're deliberately hidden for me from the time being, because we're looking at the vertical space that we need in order to create space to put either implants or a denture to restore the missing back teeth. So again, these are key diagnostic principles, and there is a system and a way which we will teach you over the 2 days in order to systematically work your way through these problems and issues that you're facing in a more advanced case like this one on the screen. Perhaps again, a younger patient, and again, we'll see cases like this that are put through on the portal. Now, this is somebody who's 27 years old, and now, idealistically, do we want to prepare those teeth? This is a class 2 Div 2 case. It's a restricted envelope case. She's overclosed. She's lost anterior guidance. And ideally, we could try and treat this, but realistically, this case is going to just lead to failure and give her a lifetime of problems down the line. So again, we will look perhaps at how we design a case like this using simple systems of orthodontics so we can deliver a predictable result like we've achieved here for this young lady, which then gives her a lifetime with dentistry needing minimal attention, apart from to refurbish the composites maybe every 10 years or so, depending on her level of home care. So again, with this case in particular, we've had to look at the vertical dimension that we need. How do we restore those teeth? How do we communicate that orthodontically? And again, across the 2 days, we'll look at cases very similar to this in terms of the best treatment sequencing in order to deliver a predictable result. And likewise, again, in a case like this, we've got differential wear here. So have we got localized wear or have we got generalized wear? What's causing this wear in this sort of pattern, and how do we treat and overcome that so we can deliver the result on the right in a predictable manner? Again, last case from a SmileFast one, again, localized anterior wear, loss of anterior guidance, patient is overclosed. And how do we therefore achieve the result on the right? How do we communicate that with the patient? How do we communicate that with a SmileFast lab? And how to deliver that? And then how do we maintain that in a predictable manner? So I'm going to touch a little bit in the next sort of section, really, in terms of some of the areas and elements that we'll cover across the few days, just to give you a flavour. So for me, the basics of good treatment planning haven't changed. Good treatment planning is good treatment planning. We need a good history. We need to understand what the patient wants to achieve and how perhaps they've arrived at the place that they're at in terms of having tooth wear. Photographs are absolutely essential, and we do a photography masterclass with Luke. So we want you to bring your cameras with you. We will therefore go through all your settings and look at your camera setup. And at the end of it, you'll be able to take some fantastic photographs that we'll be able to show, and will give us a lot more pleasure when they're on the portal and we're assessing cases that we're able to see clearly what we need to see. Radiographs, they're essential to look at worn teeth to make sure of any areas. So they still exist there. Now, this 8 parameters of success is something that we cover, particularly from occlusal and a case assessment for tooth wear. And I'll touch on this in a little bit and we'll come back to that, but it's a large part of the 2-day program. Digital smile design. Now, of course, the lab will do a very, very good design for you, but we'll also teach you and show you a program that enables you chair side very quickly and very effectively with a patient to actually communicate where that incisal edge position should be in terms of facially driven treatment planning. And again, we'll spend some time as part of the 2 days so that you can leave and drag a simple smile photograph, which I'll show you later how we very quickly do this, so that you can sit and then communicate that over effectively. Because what we'll talk about, and one of the key parameters with rebuilding a case, is determining the anterior incisal display and where that incisal edge should be. Because that for me is one of the key building blocks in moving forward for this sort of advanced care, is that functionally the case has got to be right. Aesthetically, though, the case has got to be right. And then phonetically, the case has got to be right. And all these parameters, we start for me with the digital smile design and determining where incisal edge position should be. We'll then look at FaceBow records, and we'll do an exercise on how effectively to take a FaceBow. Centric relation records are key. In all of these cases here that we'll show and coming up, all of them have been occlusally reorganized. So all of them had a change in vertical dimension. And as part of that, we will, in 99% of the cases, be building in CR. Now, centric relation is a bone-braced position. It's nothing to do really with the teeth. And therefore, the ability to predictably record that and assess the vertical dimension is key in terms of therefore designing and therefore executing on these cases. So we'll look at that in detail, and we'll do exercises with you where we'll show you how to take a centric relation record and how to calculate occlusal vertical dimension. That will then lead into what we call your diagnosis. And this is key in terms of your report writing and how you communicate and keep yourself medically legally safe. And we'll give you a template in order that you can use this. So then you can lift that template and apply this then with the patients that you then see. We'll also show you some technology which we use as well in terms of making small video recordings and screenshotting and how to write and again, effectively communicate with patients. There's a system and a process that will teach you how to use in terms of trying to convert these cases. So how to put the wow and how to keep people excited and make sure they go away, because you're going to be asking people to invest a significant sum of money into sort of a full occlusal reorganization. And then the last bit, which we all know the process, once we've done all of this, how do we then refine that? So how do we turn that into a trial smile, and what are we looking for at trial smile assessment? And then, of course, the treatment steps. And as part of the 2 days, you will do an upper and lower smile fast direct case on a set of articulated models, which will then occlusally refine and the treatment steps in order to deliver an occlusally stable result at the end of it. So with history, the etiology of tooth surface loss we will cover. We will go over abrasion, abstraction, attrition, and erosion. We'll look at cases like this and sort of say, well, how is this happening and what effect will that have on our restorations if we restore in a conformative manner? As I've said, in a lot of these tooth wear cases, there's been things going on, which we'll cover in the next slide or two, that affect how predictable our result is if we just conform. And what we all want is teeth for life, and we want to be able to diagnose this. Now, one of the key tools that we'll cover is the ACE classification, which is championed by Vilati. We briefly touch on BWE, but I'm not as big a fan of BWE. I think patients can relate a little bit more to ACE classification on the left, and ACE classification then gives you a series of treatment steps to follow. This is probably one of the key areas for me, which is these 8 parameters to consider. So what we need to look at on a case-by-case basis is the intermaxillary relation and guidance. So is the patient in centric relation? Where is MIP in relation to centric relation? Have they lost occlusal vertical dimension? What's happening to the occlusal planes, the curve of Spee and curve of Wilson? What's happening to the degree of tooth display and phonetics? How are we deciding, and are we looking at facially driven aesthetics, and where is that incisal edge position needed to be? What's happening with the gingival levels? Have we got alveolar compensatory overgrowth? And also posterior tooth anatomy, as in that case that showed you right at the back there. Sometimes the vertical dimension will be determining what sort of size posterior tooth we want to put in, particularly if there's missing back teeth, and particularly if we're considering implants. And right towards the end of this, I'll show you a case whereby it's simply presented with a split premolar that ended up in a full mouth rehabilitation, which I think predictably will give the lady that we've done all this on a better result for her lifetime in terms of rather than just conforming. So cases like this, I'm sure we're all seeing coming into your practice time and time again. You know, there are people who are now keeping their teeth, but the enamel has gone. We know the dentine is softer, and we know once we've exposed that dentine, I always use the phrase, once the elephant has been pushed over the hill, it starts to roll quicker and quicker as it's rolling down the other side. So once we're then through and into dentine, dentine is 5-10 times softer than enamel. So this tooth wear will accelerate. And people like this lady on the left, they want their teeth then to look nicer. And when the lower centrals start to get smaller and smaller, this is when they'll often present, because they don't like the yellow rings that are sort of appearing on those lower teeth. There's an aesthetic demand now to look good. Often, sometimes they're grandparents, they've got weddings coming up with grandchildren. Case on the left are younger people. You know, look at on those lower incisors, that compensatory alveolar bone growth there. There's very limited tooth wear on the lower teeth, but look at the damage that's causing on those upper teeth. And again, you may well want to conform with that. And we see cases where people just simply want to bond onto the facial aspects of those upper teeth. But actually, this case for me is a reorganizational case, and ideally would probably be orthodontics as well to intrude those lowers. So again, diagnostically, are we feel comfortable with saying overclosed, altered occlusal planes, compensating alveolar bone growth, loss of anterior guidance. We have a reduced incisal display. We showed you the smile shot. You can see the height and proportions of the teeth. We have an even gingival levels, and we have reduced posterior anatomical height. So there is no restorative space to restore a case like this. And you can see that quite clearly in that photo. But ideally, in this other case here as well, you can see exactly the same phrases. So again, would we diagnostically feel comfortable saying, yeah, this patient is overclosed. Yes, they've got altered occlusal planes. Yes, they have compensatory alveolar bone growth. Have they, do you think, lost anterior guidance? Have they got a reduced incisal display? Have they got uneven gingival levels? And again, once again, what about reduced posterior anatomical height? So this is already the system that we're starting to teach you, and how do we assess that? And some of this is very what I would call bread and butter dentistry as well. So you can see the case on the left and how we've transformed it to the case on the right. So yes, we've got a crossbite, and how do you manage crossbites predictably? And this is very simply a mixture of some bonding and a couple of new crowns on the front teeth. Not the world's most perfect result in the world, but it's actually what I would call just practical wet fingered dentistry. And I'll show you cases which I think are like this, which I think are acceptable, well managed, well executed. They're not perfect. They wouldn't win Aesthetic Dentist of the Year awards, but they're real cases. And we have lots and lots and lots of case studies like this, which we'll share with you on the day. But it's a predictable workflow, and I feel quite comfortable with patients leaving like this, that they'll leave happy, and it's something that's manageable and maintainable for the rest of their life. So when we look at these phrases like diagnosis, loss of restorative space, a lot of the time there's a loss of anterior guidance. And one of the key terms that we see with people that we hear a lot of is restricted envelope of function, or constricted chewing pattern. Because if we have a case that has a restricted chewing pattern or a restricted envelope, if we fail to respect the occlusion and we just lengthen teeth, as has happened in this case, this is ultimately what will happen. By lengthening and restoring chip-worn edges in an occlusion that's already restricted, you actually treble the increase in the likelihood of things failing and fracturing. And I put this case in because it doesn't matter if it's porcelain, because when people sort of say, well, don't worry, I'll put zirconia veneers in, they'll still fail. If the envelope is restricted and there's parafunction occurring and you don't respect the occlusion, it'll come back to bite you. So following this sort of treatment planning steps here and understanding this and how to manage this is absolutely key and paramount in managing tooth wear and reorganizing cases. So again, with a case like this, on the outset, it looks, you know, we can see it's non-carious tooth surface loss. We can see it's erosive in nature, and there's a degree of attrition. We can see the worn edges, and we can see that the patient now is starting to become overclosed. They're losing guidance because they're through onto the dentine. And if we don't help to restore this case, where is this case going to go and how is it going to end up? And at which point do you intervene with a case like this to start to protect the underlying tooth substance, so that this case therefore becomes something that enables this lady to keep her teeth for life? Now, the underlying erosive element to this case is it's endogenous, so it's reflux. You can probably tell with the pattern of wear, for those of you who know erosive patterns of wear. And therefore, on a case like this, managing that endogenous acid is something that, you know, she maybe needs a meprazole. She maybe needs to be referred to see a gastroesophageal reflux expert, so they can maybe go on a meprazole, maybe have investigations further to find out what's going on. But because that acid is perhaps always going to be there, it's going to dissolve these teeth, you know, and again, once the elephant's over the hill and we're into dentine, it's going to roll and roll and roll, and these edges are going to deteriorate. But again, using SmileFast, we can predictably restore the placal aspects of these multiple teeth here. So this is a 5-to-5 case. And then you can see the occlusion becomes better. There's a better 70-30, or I'd probably say 80-20 there. We've opened the case. We've allowed the posterior teeth to dial in, the ones that we haven't restored. And we've re-established a nice anterior guidance, protected those worn edges, and given her hopefully a result now that in years to come, yes, if we don't control the gastroesophageal reflux, the composites will suffer, but at least we can redo the composite. We can't give her a dentine or an enamel back, but she's stable for the time being. Restricted envelope cases like this. So again, classically class 2 div 2 cases, or people who've had what I call extract and retract. So fours out and the anterior teeth retracted to be put into a restricted envelope. And again, looking at these cases on the right, when people try and bond composite over the front of them, and then it chips, and then they try and repair it, and then it chips again, and then they try and repair it. I think with all of these cases like this, we need to understand how we therefore manage this and how we give them freedom in long centric, which is a key principle at the end of these cases from an occlusal concept and how to manage that. And again, we'll cover this as part of the 2 days. So where do your centric stops land and how do we adjust these so that the lower anterior teeth have freedom to move? And there's a brief, just sort of soundbite in terms of freedom of long centric. This freedom in long centric is when you can bite your back teeth and then the lower teeth are able to move forward a small fraction before contacting the anterior teeth. And the same is what we call in lateral movements, which is called wide centric. And one of the key tests is where if you put a little bit of shim paper between your teeth and pull, when you tip your head back, it should be able to pull through. So you should always be able to have that sort of freedom for the lower incisors to move within the envelope of the front teeth. And again, I'll just let you have a little read of that there. So again, the range of movement we have is known as the intercuspal contact area, and patients who parafunction have a greater range of movement, and the restorations need to allow for this, and hence cusp inclinations will be flatter and the fossa shapes will be wider. So again, people who need that ability to have side shift, again, you can't have steep cusp shapes for them, otherwise they'll simply break those off. And again, often people with constricted chewing patterns present with chipped and worn anterior teeth and often TMJ symptoms. So again, being able to look at that and diagnose that and therefore follow a treatment sequence to stop failure of your new beautiful anterior restorations is key. So again, if we go back now to this young lady, as we can see on the screen here, who we started with, this is the same lady with a little fracture there on the incisal edge, with the altered incisal planes. And if I show you this one here, I would say if you looked at that, and if I haven't got a really good palatal shot, but you can actually see notching palatally. So you can see all the telltale signs here of, you know, she's actually a class 2, slightly div 2 anterior relationship. She's got a deep bite. And actually for me to fix this case, she needs orthodontics, which she's currently undergoing. And then at the end of that, I think she'll need virtually minimal, you know, she'll need that small incisal edge where repairing, and maybe we'll put some tips rather than giving her a lifetime of composite veneers. What she's ended up with there diagnostically is the correct treatment and the idealistic treatment for somebody who's of a young age, rather than perhaps a treatment that gives her then a lifetime of maintenance and consistent failure. Because if that edge is chipping now, if I make that longer to offset this sort of big front tooth look, which she feels she's got, and to correct that smile curve from the lateral views, all I've done is made that worse by restricting her envelope of function. And all that will do is continually fracture. And eventually you'll get very, very dissatisfied with these patients coming back and being sort of the bane of your life in your book with fractured restoration. But of course, understanding how to diagnose that and understanding how to manage that is key, and it's one of the principles that we'll cover across the 2 days. And again, as I've just touched on there, there's so many patients out there who've lost freedom in centric occlusion. They have this restricted envelope, particularly class 2 div 2s, and particularly people who've had extract and retract. There's also generalized wear cases. So as Luke and I would often say, you get these hybrid sorts of cases whereby it's not just localized wear, it's actually full mouth generalized wear. And therefore it's not really just a dial case, it's dial plus really, whereby there might be 2 or 3 other extra teeth that need attention. So in something like this, this will be a generalized wear case. So if we open this up and we don't look at how we restore the posterior teeth, which are worn as well, then you can't simply allow those to dial back into place. So understanding dial, when to use it and how to use it, and when dial isn't appropriate because the posterior occlusions also need treating. Now, SmileFast predominantly deals with 5 to 5, upper and lower. So we'll briefly cover as well restoration of posterior teeth, materials that are available, and how we'd actually treatment sequence that. But primarily the 2 days focuses on sort of localized anterior wear, in particular the dial principle. But we can't really cover that without understanding what the difference is and when we need to restore posteriorly as well. So in a case like this, where if you look closely, you can start to see fractured cusps, you can see cracks in teeth. Sorry, I don't have a pointer, but if you look at the upper molar tooth, you can see the fracture on the upper right side. You can see the buccal cusp has come off. We've got the lower jaw. No, sorry, it blinked past that. And the same was happening in the lower jaw in that case. So again, how do you treatment plan and how do you organize a case? How do you communicate with the patient? How do you then write to that patient and explain what they need doing? And we'll also cover some of the finances. So more than happy to share across the 2 days what we would charge for a case like this, and how we would treatment plan that, et cetera, et cetera. Now, there's more complex cases like this. So a lot of the time we'll sort of say, look, pre-orthodontics is required. So in a case like this, again, if you were looking diagnostically, this is the case overclosed. Yes. Have they lost anterior guidance? Yes. Have they got non-carious tooth surface loss? Yes. Have they got altered and compensatory bone growth and altered occlusal planes? Yes. Have we got altered gingival levels? Yes. Will this case need orthodontics to be treated effectively? Well, I think the slides show you yes. However, in cases like this, it's very, very difficult for some of the orthodontics to position those teeth in the right position before we finish the case. And often you'll find they'll start to align gingival levels because the only place they can place the brackets is in the midpoint of the tooth, which therefore becomes very difficult with the wire to control. So again, we'll cover a little bit about uncoupling teeth as we've done in this one. And then perhaps how we would then look to then bond up those teeth and then allow the orthodontist to re-bracket up the teeth in order to then level and balance off the occlusal and sort of get the occlusal planes as ideal as we can, but with an aesthetic outcome in mind, because that's what the patient sees at the end of it all. And again, we've then got your choice. We'll talk to you about transitioning restorations. So in advanced wear cases like this, would we want to go straight from teeth to orthodontics to full coverage crown or porcelain restorations? Or would we want to stage the case by building in resin, establishing occlusion, letting them sit like this for maybe 2 years, 3 years, 4 years, 5 years, 10 years, and then transitioning to porcelain at a later stage once we've established the aesthetic, functional, and phonetic outcomes. So for me, in a lot of these cases, when we're doing full mouth rehabs, there's always a composite rehabilitation stage in there, because in effect for that for me is the trial restorations. Now, if they can sit and composite and they're happy with just having the resin refurbed, then that's great. I'm more than happy. I'm meeting their expectations. Of course, in some of these cases, the aesthetic expectations can't be met, and therefore the transition to porcelain or full coverage restorations can be made, but it can be made confidently at that point, knowing that we've tested the new occlusal scheme and that we've actually agreed aesthetic and proportions and dimensions of the new teeth and looked at shade as well. So then I think you can move confidently forward then when you're looking at full mouth rehabilitation. So in a case like this, when we get to this endpoint here from where he started, it's very easy to communicate and to sit with him, to photograph and to document, and then look at the areas that he either like or doesn't like. And again, is he being realistic in his aesthetic expectations? Well, of course, if it's in resin, we can alter and tweak and change that. If this has gone straight to porcelain, it's a lot harder. So briefly covered shim sock test. And again, with constricted chewing patterns, as I've just shown you, realistically, it's either orthodontics or restorative. So we'll cover a little bit on ortho, but predominantly the course is about restorative solutions. And again, I've mentioned the 3 essential areas: aesthetics, function, and phonetics. And hopefully you've understood now from there. Just to wind up now with some of these cases that are a little bit more complex, again, with altered occlusal planes. Now, in order to determine if we've got a lady like this, how do we know what will suit her from an aesthetic point of view? So again, when we look at the teeth like this, are those 2 front teeth too big? Are the side teeth too small? What would suit her better? So we'll look very, very quickly just at aesthetic display and DSD. So we'll cover this on the 2 days. We'll show you how to use this program. And we'll very quickly just do this now. So I'll just give you a very quick overview.
So smile design, and what we'll teach you on the course is how to use a certain software, which enables you to then sit with your patients and play around with where you determine incisal edge to be. You can lengthen that a little bit, and we'll teach you how to set this all up and play around with all the different parameters, get the correct height to the width ratio. And then when you're happy with that, that'll instantly render then into a smile for the patient. And we can play around with two shape. You can even play around with color and match it up a little bit and change it. And we can make that brighter if somebody wants to have a little look at what they look like with really, really white teeth. So we'll cover that all as part of the course, but just to give you a little snapshot.
So as I say, one of the most powerful tools that we use that will teach us how to do this. It's fairly cost effective, but very, very powerful. We'll teach you how to record this, and a little system that I use then to send this to the patient so that they can share that with friends and family. So again, it's converting these cases when they come in like that. I think that's one of the fundamentals. Sometimes you go on these courses and they'll teach you all the sort of theory behind it all, but actually some of the devil in the detail is that essential communication with the patients in order to sort of portray confidence that you have a system in order to do it. So again, aesthetics, where do you want the incisal edge to be? We can determine that digitally. We can then go through into the SmileFast system to mock it up and do a refine and a trial smile stage. We'll talk to you about average height and width ratios of teeth. So again, what's the interdistant distal to distal width of centrals? Therefore, how does that determine what the length and where the edge should be? How do we measure that, and how do we communicate that to the patient? So again, ultimately, what it comes into is it's cases that we see which are like this. So a classic being this is a localized anterior wear case. Non-carious tooth surface loss. We have a restricted envelope. We've got exposed dentine. We'll teach you how to do your digital smile design and play around with that till you determine the incisal edge position. You'll teach you how to calibrate this program so you can measure and effectively tell the lab, you know, we need to add 1.5 mil to these teeth here. Here's a picture of where you want to do it. Please do me a design. They can come up with your own design like this, or you can get the lab to do it if you want to. We'll teach how to do a centric relation bite and how to capture that and communicate that to the lab, either analog or digital. So we'll cover that with iTero scanning. Or you can do both if you want to. So you can scan this and send it, or you can capture it. And we'll talk you through how to use a leaf gauge, an anterior midpoint appliance, a COIS deprogrammer, all of those. You all know this if you're using SmileFast, how you then refine and assess that, photograph that, and again, record that and communicate that back to the patient. And then ultimately, how do you deliver a nice result like this that gives a nice predictable anterior reconstruction of a localized wear case using dial? We'll then look at the occlusal elements. How do I set this up and how do I adjust this? So what aesthetic endpoint do I need to get to, and what occlusal endpoint do I need to get to deliver a predictable result? And we'll talk about idealistic versus realistic. Where do I leave my centric stops? What sort of guidance do I have in excursive? Do I need canine guidance or do I need group function? Where do my centric stops need to be? What should protrusive guidance look like? And what should crossover in wide excursive be like? So again, lots and lots of words and concepts and lots of bits that will give you a practical. And we'll do a practical sort of exercise on this when you're doing your upper and lower SmileFast on your mounted models. You'll sit and adjust this all in. So hopefully you'll leave with a really good understanding. Now, one of the big areas in tooth wear for me is also lower anterior teeth. And this is an area that's poorly understood. I think it's poorly taught, but it's something that we need to learn how to assess. As I can see in this picture here, at some point, there's going to come a point where that anterior guide plane needs to be flattened. And on occasions, you're going to need to build up the lower teeth as well as the back of the upper teeth. Otherwise, you can see in this picture here, it just gets too steep and you're likely to get then a restricted envelope and you're likely to get anterior fracture because you've actually restricted it. So in the case on the right here, as it moves forward, there's going to come a point where the lower anteriors are built up. So we'll cover lower anteriors as well, and we'll do a lower anterior case. As I said, you do 2 cases, an upper and a lower. And we'll look at how you assess that and say like a case like this with a non-carious tooth surface loss. They've lost anterior guidance, they're overclosed. We've refined that. We've assessed that with the patient. It all looks good. We've done the intraoral assessment. And then we're able to deliver then a nice predictable result. In this case, it's a mixture of crowns and bonding on the lower teeth. And now we can see the final result there. There's crowns on the premolars, bonding 3 to 3, crown on the lower left canine, bonding on the 2 premolars, and finally a crown on the molar on the other side. There you can see from there. So for me, a nice predictable results, what I would call bread and butter dentistry. Again, we will cover cases that can't be done with SmileFast, and there are some that can't be done because they're just too crowded. So in a case like this, where orthodontics isn't an option due to the amount of alveolar sort of bony movement, full mouth rehab on the upper jaw, which would have had to be completely disassembled. But can we give him and can we protect these teeth? And we'll cover a little bit on edge bonding and how to do that. And there isn't a practical exercise on it, but we will talk you through about how you do that. So SmileFast, whilst it's available for lots of things, there's certain cases like this that you can't do with SmileFast, but the principles of tooth wear and tooth wear management and occlusal and reorganization and controlling the OVD are exactly the same for cases like this. Right, winding up now, last one here is we'll cover a little bit of multidisciplinary care like this. So this is classically a case that I see in Yorkshire where, you know, normally this would have been a clearance. You know, 30 years ago when I qualified, somebody would have presented like this and they'd have had to have all their teeth out. Nowadays with cases like this though, where budget is a factor and full mouth crowns aren't and implants aren't perhaps on the board, we can still rehabilitate a mouth like this. We can look at where his smile curve is. We can have a discussion about whether we're changing the crowns, whether we're leaving the crowns, but how on earth do we restore these teeth? What height, what occlusal plane do we work to? How do we determine that? We're looking at the refined stage now, and how do we assess this and how do we determine whether this is right or not? Is this correct or do we need to adjust this, and what determines that? Because the bottom line at the end of it all, when we get to it, is we want to try and deliver a result like we've got here. And, you know, again, for me, this is what I would call bread and butter dentistry. What he had originally was an old cobalt chrome at the top here, which was refurbished by a local lab for him once we'd rebuilt these lower teeth. And as you can see, that's the cobalt chrome with the refurb teeth on. And we left the existing crowns on because it wasn't in his budget, but we felt we could restore the teeth on this top right-hand side with bonded composite onlays. And then we rehabilitated the lower teeth and we popped a couple of implants in the lower, which was within his budget to do that, to give him enough posterior support to provide him with a stable result. And this is the last case, again, using a little bit of implant. And we'll cover this as well a little bit on the digital planning of this. But this was a case that presented with overclosed, but had fractured and split the premolar on the upper right area. So we'd lost anterior guidance, and I felt if we replaced that one tooth on its own, it was likely to simply go the same way as the other one. So we had a chat to her. She didn't like the shape, shade, color of her teeth. So we were able to do SmileFast Direct on the upper and lower teeth to re-establish the guidance and to re-establish the posterior planes. We used our DSD program in order to communicate that effectively with her. We then lifted that into Exocad, and that was communicated back to me so that I could look at the new occlusal scheme. I was happy with it all, so we then delivered that. We communicated that through the centric bite. And then we got from a situation where I felt we were overclosed and had lost restorative space, which would have given a premolar that looked too small in a buccal corridor, to enable to open her up to give her a premolar that we delivered on the left-hand picture that's balanced functionally and stable that we've done with an implant. We lifted all that diagnostic planning.
So just very quickly,
then did that using a digital program.
So as you can see, what we've got is the 3D design of Case's new smile, and we've simulated the new tooth position and where we want it to be. And then what we've done is simulate the placement. So this is what we've done as a SmileFast implanter learning. So a quick plug, and you can see it's nicely within the bony housing, its emergence profile, everything looks good. You can even put an abutment on. And then once we've got that, we can then produce the surgical guide. So that's how we then predictably create the guide, which enables us to place the implant in the precise position so we can get the final result that you'll see on the final picture.
So again, just something that we'll cover as part of it for those of you who are involved in implants. How do you plan posterior occlusion and how do you manage the spaces? And the last thing, which we'll touch on right at the end of the day, is maintenance and what sort of bite guard and splints do we cover? When do we use a Michigan? When do we use an Essex? When do we use a nighttime bite guard? And what's the difference? What are the benefits? What are the pros? What are the cons? So hopefully that gives you a bit of an idea in terms of what's going on in terms of Smile Fast Restore. So I know I speak quickly, and I know I'm always moaned at because I go through things at high speed. So I tried to give you an idea of what we would cover in 48 hours. There's an evening where so the day starts about 8:30 in the morning, and we usually finish around about 6 p.m. on the first day. There's a meal that's included in the evening. I think, Asif, hopefully I'm not there. I know it's usually are, but we all go out for something to eat together in the evening. And again, lots of learning takes place in the bar and when we're having a drink and a bite to eat as well. We encourage you to bring your own cases. We will treatment plan all of them for you and with you, and hopefully enable you to upload them into the SmileFast portal so you can then deliver the cases predictably. Normally we wind up now. That's me sort of fully out of words after about 45, 50 minutes. If there's any questions, normally I think we pile them into the little box at the bottom. In terms of chat, I think, is that where we want to have it, Asif, in there? So if there's any questions that you want to put in there, I'm more than happy to answer any questions if anybody's got anything. So we'll give it a minute or two. If not, and everybody is happy, then Asif will be in touch. I know we've got a couple of spare places still left on the upcoming course, which is in Manchester in October. And then there'll be probably 2 or 3 courses next year in London and probably Manchester again. So if you want to register your interest, if you want to let Asif know after this, then he will keep you in touch about the dates that Luke and I are doing next year as well. I don't know, have you got anything to say, Luke, at this point?
Just been a silent stalker, John.
Yeah. So I don't know, is there any questions from anybody that anybody would like to know or would like answering? I don't know if you want to type anything into the chat. Or in the Q&A. I don't know whether that's open for everybody. If not, I'll give it 1 more minute. So there's one popped up now. Please didn't know about the course. Yeah, not a problem at all. Alexander, we'll definitely do that again. Asif, I think everybody had to sign in with their email address. So if they've all done that, then Asif will post some dates for people. The London course, which will be held at Heathrow, Asif, would that be correct?
That's right, yeah. Our London courses will be held at Heathrow. We don't have dates for next year just yet, but we will be looking at probably February or March. As soon as the dates are ready, I will get those shared across our mailing list and on our social media channels. Yeah.
I think it's basically Luke and I will sit with Asif when we're yes, Iman, I'm sure Iman works. So will I be able to get a discount on the course? You'll have to ask Asif. I'm sure he'll be able to sort something. And we'll get you some dates for definitely next year. So I think what will happen is Luke and I will sit when we're in Manchester in October with Asif, and then we'll come up for the dates for next year. I know SmileFast, it's a very busy year with the launch in America and the dates and the training throughout the year. The new stent and guides have just been launched, and the SmileFast implant, which is going on. So as a company, it's very, very busy. So there's lots happening. So it's just fitting the dates in and around the logistics, because to run these courses, the amount of equipment, etc., that's needed, it's very logistic heavy. Okay, so Ben has just asked, when restoring with an increase in OVG, is it achieved with the SmileFast direct splint? Yes, in effect, Ben. What we will teach you and what we'll show you how to do is capture centric relation at the correct OVD. So that then when that's sent to the lab know what OVD to work from. I guess one of my frustrations is that we see a lot on the portal is people just sending stuff in and expecting the lab to guess. The technicians aren't clinicians. It's not their job to diagnose. It's us at the clinical end who are dealing with a patient face to face. It's our role. We're the dentist. We're the sort of operator to be able to deliver that. So part of what we need to learn and understand is what we need to assess in terms of what a correct OVD should be, and then how do we communicate that in centric relation to the lab. Now, of course, there can be a little bit of tweaking, So once that's back, and if we think the vertical is a little bit too open, then of course we can say close that down, reduce some of the bulk, etc. But the actual position and rough guide is really what we'll sort of explain to you and teach to you. And then of course, once we've got that, then yes, SmileFast Direct is a very, very effective way. So most of these cases that you've seen here have been delivered with SmileFast Direct. Not all of them, but most of them. And yes, the stent, not splint, yeah. So the actual SmileFast Direct stent can deliver you the full mouth rehab. So that last case that I've shown you there with the implant, that's full SmileFast upper and lower. And the case with the worn lower teeth and the chap with the denture, those lower teeth is SmileFast. The other one before that on the lower teeth, that's a SmileFast case as well. Where we used the crowns, we delivered the resin on the cases that needed resin, and crowns are on the case. We just use it, still part of the same design.
The new stent is so much better as well, isn't it? In terms of, I'd highly recommend if anyone is using it, hasn't used it yet, definitely try it.
Yeah, the cleanup, fit, everything about it is just so much superior. Right.
I think that's all the questions answered. We've got a few questions
Yeah.
around the next set of course dates. So I'll reach out to everyone that's asked about them and let them know once the dates are ready. Sorry, John.
There's one
question.
Yeah, how does condylar angle get recorded if using digital? So one of the things that we'll cover is face bows. What does actually a face bow do? How many people are actually using Cadillacs or something like ModJaw? So we have ModJaw, for instance, and condylar angle. Do you need to go to that level? Because I would probably reckon that very, very few people in the UK are using Cadillacs or are using ModJaw in order to calculate condylar angle. I think you can look at condylar angle and therefore you can adjust it as part of what you look at when in protrusive movement to see whether it's balanced. I think there's a lot of cases where condylar angle, if I was looking at low, medium and high facial angles, so as part of that, in terms of looking at the facial skeleton from the lateral view, and those of you who understand and do orthodontics would look at your FMA angle. Is that low, moderate or high? And that's where I think condylar angle, particularly when it's a low angle, is an effect for anterior guidance. I think in all the other cases, you're probably going to be fine. But I don't know whether you agree with that, Luke. It's really in those low FMA cases that you need to look at the steepness of your anterior guidance.
Yeah, I concur. If anyone's got a perfect answer how to do that digitally, they can send that one to me. I still have that missing piece in the puzzle. So I'm not going to invest in ModJaw just yet. So
yeah, we're playing with ModJaw at the minute. We've had it about 8-9 months, and it's quite a steep learning curve on it. Me personally, I do think it's the missing link because you can take data, but that's because 2 days a week in the referral practice, we're seeing failing rehab cases. So we've had 2 in today, which are
you were meant to say it was rubbish, John.
The problem is on the cases that go wrong, Luke, they're always, if I showed you the body and face type, it's always generally on men with big round
Bulldog
square
Mr.
heads.
Brady Kafik,
and they have, they don't fit into a DNR face bow and set on average values. Therefore, how do you predict and how do you set those cases up and how do you electronically record? And I think that's potentially where ModJaw can help us. But fortunately, the human anatomy helps us in the majority of cases, which is why average value is generally okay. But it's learning to spot the ones before they fail. That's the key thing.
I think we might be there, mate.
Yeah, I think so. It's 3 minutes to line. I've wolfed some tea down earlier. I need a pot of tea now. True Yorkshireman, I need a mug of tea.
Okay, brilliant.
Right.
Thanks very much for that, John and Luke. I will get this uploaded and sent out and put in the various groups as well. So if anyone has missed it, they will get an opportunity to watch it as well. Okay.
Yeah.
Excellent.
Okay. Thanks very much, Luke. Thanks, Asif. Thanks everybody for listening as well, and have a good evening and a good weekend.